Okay, hi everyone. My name is Amy Tanzillo, owner and founder of Thrive Breastfeeding. Um, how I typically hold these classes is I just talk and we hold all our questions till the end. But I was thinking today, since our class is fortunately smaller, we could just quickly go around. This would be a little bit more personal with this class because it's a little more of an intimate size. And just if you want to, and if you want to pass, if you're multitasking, that's absolutely fine. But just your name and when you're due, and if you're having a boy or girl, and most importantly, if there's one thing that you're dying to know, like you heard you need to do this, or is it true that, or something that you're really concerned about, and I'll make sure that I cover it in our class today. So we can just go around the room, and if you guys, I believe everyone's able to turn on their microphone, and then we can just start. Christina, you've been on first, so I'll let you go first.
Hi, I'm Christina. I am due August 17th, and I'm having a boy.
Awesome.
And it is my first, as I'm sure you're all firsts, maybe. But yeah, I mean, just generally everything. I know nothing about breastfeeding except for what I've learned through you through Instagram. So I'm
Awesome.
just here for all of it.
Okay, great. Thank you.
Thanks.
We'll just go around the squares. Christine.
Yep, I'm Christine. I'm due August 21st with a girl, first child. Just in general, all of my friends have told me they wish they took classes or got their own consultant. They all had issues or troubleshooting. And then by the time they did reach out to somebody, it was course correcting and a whole process. So to get ahead of it. And then that's what I'm trying to do.
Very smart mama. Okay, thank you. Lindsay.
Hi, I'm Lindsay. I'm due on July 5th.
Oh
so
gosh, soon.
Yeah. I was referred to this course by my friend Lauren. She lives in Virginia, which I'm assuming maybe you guys do too. I live in Texas, so I'm not anywhere near, but yeah, I'm really excited.
Lauren Russo.
Yeah. So I grew up with her here in Texas before she moved to Virginia whenever she was like 12. So we've been friends forever.
She's wonderful. For the others on the call, Lauren Russo is a birth doula, and we are buddies also. And she referred Lindsay, as she said, and she's wonderful. And we could even touch on this, but you know, your doula can be such an advocate during birth and be such an invaluable resource. And that's what Lauren does. Her company is called Fairfax Birth Care. Yes. And I'll send that in the follow-up email also. So thank you. That was good that I was able to mention her. Okay, Lindsay, is there anything that you want to make sure that we cover?
I don't even know what I don't know.
Okay, that's fair.
You know, I've heard people either like, I've just heard that it hurts so bad, or my nipples are cracked and bleeding, and that's terrifying to me. So anything that would help with that.
Okay, that sounds awesome, doesn't it? Okay, and Claire?
Hey everyone, Claire O'Doherty. I'm due August 14th. I feel like we have the 7th, the 14th, and the 21st. It's like
it's a play group in the making.
We'll have to stay in touch. I'm having a girl, and I think I would really love a little bit of like how to introduce bottles, and like, you know, I'm sure as we all would love to have our husbands take on at least some of this from just like helping and you know, night feedings or whatever. So would love a little bit of info on how to make that happen. And then I obviously it's my first, so no idea what and would love just any information.
Okay, great. And we'll definitely cover that. And that's on the agenda, is when to introduce a bottle. And Paula?
Hi everyone, my name is Paula Castillo. I'm due July the 27th. And interestingly, this is my second baby. I had a very rough breastfeeding experience in my first baby. I arrived to a lactation consultant in emergency mode. The first letdown of milk was delayed. I had undersupply. I had infections. my baby had a tongue tie, and I didn't sleep well, and I had postpartum depression. So part of, I guess, the aim of this course is to understand how to um, get get take measures to enable a stable supply from early on, and to understand how that would look. I understand, or I have a lot of friends that start pumping from the hospital. How is the colostrum management of that?
Mhm.
And how to keep a healthy supply while providing also milk through the bottle, um, breast milk, hopefully. So because I want to sleep more this time.
Yeah. No, that's good. And it's amazing how many second and third time mamas that I have that reach out to me before the baby is born and have me booked. And it's just so smart to be proactive and have someone on standby, whoever it is, instead of going into that like emergency mode when you're sleep deprived and so emotional and so overwhelmed of trying to like look on your insurance and Google who's available. And you guys are all summer babies. Who's on vacation when their kids are out of school? So very, very smart. And I'm so glad you mentioned the postpartum piece. It's so common and not talked about nearly enough. And I think 100% of women get some type of postpartum anxiety, because I'm telling you, you have never, ever, ever loved anything. Like you can't even wrap your head around it as much as you'll love this thing that you're going to come out of your body. And it's very, very overwhelming. Wouldn't you say, Paula? I mean, it just, I think, kind of blindsides you. How I would always say, like, I thought I loved myself. And then I had my first, and it was like, oh my gosh, I would literally jump in front of a train for you without hesitation. So I think that comes with a lot of emotion. So I have another fantastic resource. She's based here in Vienna. I'm going to include that in the follow-up as well. She's a perinatal therapist, Megan McCutcheon, and I can send that to you guys as well. And another one actually in Alexandria. That's just so nice when you get kind of like in with one perinatal provider, because we're all connected to each other and kind of, vet each other out, and then we can really give you other recommendations for a holistic care. Okay, and Eliza. I think you're on mute. It's okay. Take your time. And another thing, guys, why Eliza's trying to get off mute is Megan and a pelvic floor PT buddy of ours is actually opening like a perinatal office here based in Vienna, which is going to be awesome. Like I'm going to be in there. You have your acupuncturist, infant massage, and they really are trying to create this place where moms can come and have all this care. Yeah. And also if you don't have to worry about it. If you want to chat, use the chat function, and you can kind of play around it. I'm actually comforted that there's a technical issue, because it's always me. Okay, so I'm going to start presenting here. We are going to cover a lot of information in a very short amount of time. So I'm definitely sending the recording to you guys. I'm going to kind of blitz through it. I probably am more of a bullet points communicator anyway, so this will work well. We're going to go over breastfeeding in the hospital or after delivery, if that's either in the hospital, a home birth, birthing center, wherever you have the baby. I don't think that that's really talked about too much of what do you do with this baby in the first 24, 48 hours of birth, and then latch and positioning, and then pumping. And those are like 3 high level things that we'll go through. Again, I typically save questions until the end, but you can certainly interject if it's relevant, to what we're talking about at that time. If you don't want to talk and put your microphone back on, just send it in the chat. So, okay, we have another July 6th girl. Gosh, we really do have a play group. I mean, if everyone's local, I could put you guys in touch with someone. Okay, and was it a girl, Eliza? Yes, baby girl. Awesome. Okay. And I have a July baby. So if you guys need birthday party ideas, that's kind of yeah. interesting thing to do when everybody's out of school. Okay, let's get to it. So I'm going to present now. Do we see it? The PowerPoint? Oh, here it comes. We good? Is it big enough? I'm definitely a granny when it comes to technology. You guys can see the slide okay?
Yep.
Or do I make it full screen? Or it's good?
I think it's good.
Okay. Okay, so preparing to breastfeed. We know our agenda. I've said enough about me. I help mommies and babies with breastfeeding. I do all in-home consultations, nothing virtual in terms of appointments. I never even did that during COVID. I was super careful with masking up and shielding up and gloving up, but I think it's a service that really needs to be done in person. It's just invaluable. Sometimes crawling up in the bed or getting in there and literally helping you get the baby on. So that's the service that I provide. Okay, so we're going to talk about breastfeeding after delivery. Everyone, you can even nod your heads. Everyone's delivering in a hospital? Yeah, okay. So we're going to talk a lot about how to latch and position your baby, but for right after delivery, we're not going to get there yet. I want to talk about literally the first feed. So you have the baby, and the goal is initially, and this all supports breastfeeding, is to have the baby come to breast, right? And put there on your chest. And one of the things that I've learned from now connecting with all these doulas and birth doulas, Lauren being one of them, is that, it was common practice before to have your baby whisked away and put in that incubator thing and do all the tests there. I would advocate, and many hospitals now support this, to have them look at the baby and assess the baby while baby's on your chest. Okay. And you can kind of delay having anything done to them away from you. In terms of breastfeeding, your goal is to breastfeed this baby within an hour of birth. Okay. And I feel like sometimes in the hospital, and again, my Lux clients have access to me prior to birth and throughout the birth. And there's a real preoccupation with feeding the baby immediately. And I'd love you guys to keep in mind that it's not like they come in and are necessarily starving or need to eat immediately, or they're going to, waste away. They have fat stores on them. They just went through a really long journey. So we're just going to kind of like wait and see what they do. So yes, Lindsay.
So I have some like complications and stuff. So I'm having a C-section.
Yes.
And so what I know that they're to like close me up and I got to go to recovery and all those things. So is it still possible to do it within an hour in that scenario?
Yeah. And where are you delivering?
I'm in Texas.
Oh, you're in Texas. That's right.
Yeah.
Okay. So I would connect with the labor and delivery, or if you're getting the doula there before, but even if baby is able to come up to you, right?
Mm-hmm.
Right after, and don't even get preoccupied with actually putting them to your nipple. I think for C-sections, we're just really going to focus on, because again, if you don't feed that baby in the first hour, even first, whatever, things happen all the time, that's not the case. You aren't messing up anything with breastfeeding. You're not sabotaging anything with your supply. This is just like an optimal scenario. But I do love the Instagram post where baby is like right up to mom, like almost immediately. And I would advocate for that. I don't know if you guys seen it, but there's one I saw recently where the mom was having a C-section. I'm like almost ready to start crying. But the baby had like its face, the hand on her little face. Did anyone see that one?
I did. Yeah.
So that's kind of your goal. And dad or partner help advocate for that, but just have that baby touching you. And then you're going to breastfeed that baby as soon as you're allowed to. It's just an advocate of like, oh, I really like to put my baby to breast, but there is something about safety and everything like that. So once your baby is able to breastfeed, that's soon enough. Okay. So baby comes out and baby is to chest, and we're just going to hang out with them. and let them do their thing. And you're going to be like so emotional, like, oh my God, look, here you are. I've been waiting to meet you. And we're going to, can you guys like see my whole chest? Can you see me? We're good. You're going to let the baby kind of do its thing. And a lot of times they actually crawl down to the breast. There is an amazing video. It was filmed in India. I'll send that guys to you too. But babies literally crawl down to the nipple themselves. That's why your areola gets darker, because then there's a target for them. And those Montgomery bumps around your nipple, the Montgomery glands, actually secrete something that smells like your amniotic fluid. So it's just really cool to just let them do their thing and go to the breast. And you may need to help them and scooch them down. But the things that we're going to talk about with latch and positioning, I don't want you thinking about that so much in the delivery room. We're going to get into the technicalities once you get into recovery. But you let them there. They may lick or snuggle or muzzle and just do a couple sucks, but they don't have to do like a full feed. Okay. And then you go to the recovery room. Anyone have a guess of how often you're supposed to put the baby to breast in the first, gosh, even like 2 weeks? Yes, every 2 to 3 hours. Exactly. Yes. So your milk is readily available for them. It's colostrum there in the hospital. I bet many of you, especially our July 5th baby, would be able to actually express colostrum now. You know, you would be able to compress the nipple and see colostrum there. And this is the dense yellow milk. It's very thick. It's packed of nutrients. It's really the super food. It is the perfect thing that a baby needs at birth. And it's really all that you have in the first few days. It provides the nutrition. It has the antibodies. It has that natural laxative in there to move that meconium out. And what is really, really a misconception out there, that this is not enough for your baby. And it's the perfect amount. When your little guy or girl comes out, their stomach is the size of a marble. So when you only see drops or a very little amount, that's the perfect amount. And I think that many, many times moms, as not as educated as you're going to be going into this, just think like, how could that possibly be enough? Or they start crying, they're hungry. And that's in many, many cases, not what's going on there. So I don't even love that expression that your milk is coming in, because that almost sounds like you're waiting for food, which you're not, right? You have the food there. And then it transitions over the 3 to 5 days as you know the time goes on. But this is your colostrum. When moms say all the time, like, well, I only had colostrum. Well, that's what they need, and that's enough for them. So, and we'll talk about how you know that that's not enough, but in most cases, that's all your baby needs. So you have the colostrum. It's readily available for the baby once you deliver them. Many moms can even express it before delivery, and then it will transition to more mature milk. Average time that a milk comes in is day 3. C-section mamas, day 5. Mamas closer to my age than probably all your guys' age, it's going to be delayed as well, or there's a higher likelihood that it's delayed. And that's when you'll feel your breast getting heavier, fuller, and your milk's coming in. But again, the colostrum is all they need until that happens in most cases. And you'll be able to tell that it's coming in because it's more yellow in color and just a more copious amount. And I have, again, just, you know, past clients, and this is meant to like ease your mind, where they say, oh, I was separated from the baby, or, you know, the C-section post care took a lot longer than I needed, and I didn't put the baby to breast, and now I'm not going to have any milk, and I'm going to have a low supply, and they had to take him in the NICU overnight, and I didn't put baby to breast, and I'm not going to breastfeed. And that's not how it works. Your milk is coming in from delivering the placenta. So even moms who are completely separated, is it optimal? No, you know, stimulation to the breast gives the brain the memo for the milk to come in, but your milk is going to come in. So it's all like positive juju in terms of the body is working for you. So your milk is going to come in most cases, no matter what. So you're in the hospital, they weigh the baby at birth, You just have these little tiny drops. You have dad or partner or your mother-in-law saying like, is that really enough? I think that's hungry. Johnny used to eat a lot more than that when I had him. You're going to hear all these different things, right? And the marker at this point of their life is their weight. Okay. The marker is, are they getting enough to eat? Is their weight. So you're going to expect your baby to lose weight. C-section babies even typically lose more weight because they're inflated with fluids from surgery. So they even may lose what looks like more weight, and it's not even weight, if that makes sense. So everybody's baby is going to lose weight. The ceiling is 10%. So that's your marker, is like if they're not getting enough to eat. So they are going to weigh your baby at Sibley Hospital in DC. It was 12 midnight every night and keep a track on weight. So when mom is on day one and she's texting me, should I supplement? The nurse is saying supplement. Do I need to? The first question I ask is, well, what was its weight? Well, they haven't even weighed him yet today. I'm like, okay, well then we all just need to hold on. So they are able to lose 10%. We want them bottoming out at about day 4 and then climbing back up to birth weight to be back up to birth weight at day 14. So I have an 8-pound baby. I don't know what 10% of that is, but let's say it's 7.2. He can get down to 7.2. And we want that not going any lower by day 4. And then on day 14 from here, he needs to be back up to 8 pounds. Okay. Any questions on that weight? And then the other thing is tracking the diapers. They also give us a great context clue. You know, if they haven't weighed them yet, or sometimes they're saying like, oh, the weight isn't accurate because the scale or, you know, the fluids that they were given, it's not accurate. I think that they need to do this or that. The diapers tell us the story. So I actually have a chart of this. I'm going to make sure I write this all down. So what I'm telling you guys, I'm going to send you to tell you how many diapers they need. But I had my baby today. I need to see 1 wet and 1 poop. Tomorrow, 2 wets and 2 poops. Sunday, 3 wets and 3 poops. Monday, 4 wets and 3 poops. Tuesday, 5 wets and 3 poops. Whatever number I'm on Tuesday, 6 wets. And then that's where the wets cap. So your baby at day 6 needs 6 to 8 wets and 3 poops. And that's kind of giving us a really good clue if they're getting enough to eat in the meantime between weighs. Have you guys seen like the newborn poop? It looks like black tar. And then it transitions. And we want it transitioning to a Dijon yellow mustard color by day 4. So it goes from black to brown to green to Dijon mustard. I'm at a mom's at day 5 and the baby's still pooping meconium, the black, or even just a little bit brown. Baby is not getting enough to eat. So those diapers give you those context clues there. So now we're going to walk to latch and positioning. But any other questions about the first 24 or 48 hours of the hospital? Okay, great. I think that's where a lot of my mamas get scarred, especially the ones that if they just reach out in a frantic and we haven't been together all along the way, where they just kind of get in their head that something they did at the hospital messed everything up. You know, even I'll see a mom out like with a 6-month-old baby and she goes, well, in the hospital, I let him go more than 3 hours. There's nothing you can do at the hospital that's going to like, you know, you're only there 3 days, in most cases 5 for C-section, that's going to mess things up. So I think that that's good to know, to take some pressure off yourself. A main part of the hospital too is you guys just taking a minute after delivery and healing and resting. So latch and positioning. You guys, I'm sure, have heard that breastfeeding hurts, and that is probably my biggest soapbox. Breastfeeding should not hurt. It shouldn't hurt in the beginning. Your nipples do not need to get used to it. There's something going on if breastfeeding is painful. Cracked and bleeding nipples, it's just not normal, and it's not how it should be. And I'll hear all the time, well, my mom said it took like a month. No, we were going to nip it in the bud. And in most cases, it's how you're holding the baby. So here is my breast, okay? I want you guys to take your tongue and put it right behind your two front teeth, and you're going to feel those ridges. Okay, it feels like a washboard. And now take your tongue and go to the back of your mouth, and you feel the juncture of the hard and soft palate. Feel it has a nice little arch, and there's a little pillow there for your nipple, and there's clearance at top. So what is almost always happening when mom's having pain is the baby is latching here. And that nipple is being pushed up with the tongue up against that hard palate and sending you to the ceiling. I mean, it's a hard palate. They are sucking to survive. It really, really hurts. And sometimes you may hear like, well, it hurts for the first 30 seconds, but then it's fine. So what's happening in that case is it hurts, ow, 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 ow. And then they get on deeper, and then they're in the nipple's in the safety zone. And that's where the nipple is safe. But we don't even want the 30 seconds, right? So instead of the nipple landing here, right from the get-go, we want the nipple to land here. So probably the biggest takeaway from this class is your nipple needs to land in the back of the baby's mouth. And they don't slurp it through like a piece of linguine and rake your nipple across the hard palate on the way. We need the nipple to land here. Like, oh, okay, that's fine. Instead of, oh my God, oh my God, oh my God. Or some moms that the baby's there the whole time and they just have pain throughout the whole feeding. And you don't want to power through because the nipple tissue deteriorates very, very quickly. And you have to keep going back to it, right? Delivery, you get the baby out or have the baby and there's a finish line, you're fine. Like those contractions were something else, but I'm done. With breastfeeding, you're not done. You keep bringing them back and then back and then back. So your nipple needs to be healthy. So as soon as it hurts, we stop. And then we relatch, and then maybe eventually that you would need some help there. So how do you get this nipple to land in the back of the baby's mouth? So we are going to go over the positions. The most common one for a brand new baby is the cross cradle hold. And most moms hold the baby incorrectly, and then that impacts the latch, and the baby doesn't get enough, and then it hurts. So you guys probably all have the PDF where it walks through these steps, but if not, I'm going to send that as well. Okay, so you have your baby, and the positioning is you're going to put his belly button in line with your other nipple. So he's this high. You see how high this guy is? And I don't love the boppy and the breast friend, but some moms absolutely love him and they need him, but we would need to rig it because if you were just to put your boppy on right now, you're going to see that they're very low. We need the baby up this high, not down here, right? This high. So he is in a straight line like a side plank facing me. His chest isn't towards the ceiling. He's not kind of half turned out. His head isn't turned with his body up. He is side planked to me like this, okay? Now, this arm, which is holding him, I'm going to pin in his diaper with my elbow and put his spine in my forearm. And then I'm holding the back of his head with my thumb and my ring finger, okay? If I was to stand up, I would not drop my baby. That's how securely I have him in my hand and arm. And we need it to be like that because you need to create like a door hinge. See here? You want to bring baby to breast. You don't chase them with your boob. Get in there. She said deep. No, you bring baby to breast. And that's your best shot of getting that nipple to the back of his mouth. And now this hand has a very, very important role. And whenever I tell mom, go ahead and compress your breast so we can get the baby on deep, we all do this. I think it just feels more natural. Well, if you're putting your baby across here and we're trying to make a skinny sandwich out of your breast and you're holding it like this, you're asking him to eat the sandwich like this. Does that make sense? So it feels weird, but you're holding your breast like this. See how it's making a U? So maybe just put your hand up to your breast because you're going to feel how weird it is. Like this is wrong for cross cradle. You got to come underneath like this. You hold. And I could never remember C, which is for football, or you hold. But look how where your thumb is, it always makes a mustache for your baby's face. So if I'm holding it like this, the mustache is lined up with his ear. That's not right, right? But if I'm holding the baby like this, the mustache is in the right place. So we want to go baby to breast. And when you bring him to you, you're lining up the nipple with the nose. See that little first slide there? You're doing nipple to nose. You're not putting the nipple straight in like this, but you're leading with the chin and going up and over. So they get on as deep as they can. And if you can think of a sandwich, I probably tell from my accent, I'm a Jersey girl, that's really big and that you need to get the whole thing in your mouth and it's clearly bigger than your mouth. Mine would be a hoagie, right? And it has the lunch meats and the lettuce and tomato and the big roll. I have to compress it down. I'm not going to get anything in my mouth, right? But if you guys pay attention that next time you have a burger or a hoagie, you actually put it above your mouth. You line it up more with your nose and you lead with your chin and go up and over. And that gives you a better chance of this nipple landing in the back of the mouth. And you're also that close because you want the end result. I don't even love the last baby's top lip. It's okay. But what you're looking for really, his bottom lip looks awesome. Do you see how the bottom lip is flanged down like this? That's what you're looking for. And the top lip needs to be completely flanged up like this. So if you have a total fish, see it? That's your best bet of the nipple going all the way to the back. If you put the nipple straight in and the lips catch and they're like this, it's no good. And that's when they're not deep enough. So that's a big thing on the latch. You're compressing with the U-hold, baby's up at breast height, you're bringing baby to breast, leading with the chin and up and over. And their end result is a baby with flanged fish lips. That is the most common. When they are floppy, like a rag doll, brand new newborn, and it's so technical, I recommend that you're holding the cross cradle pretty much throughout the feed. Because what happens is if you let go, their head is the heaviest part of their body. They kind of slip down and pull your nipple with them, and we don't want that. But as they get more head and neck control, and as you get more comfortable, you're going to graduate to the cradle hold. And the cradle hold is you're like this. Okay, he's on. It doesn't hurt. You let go of your breast, come around to his diaper, and then this hand is free. And I can scroll, have a drink of water, and it's a much more comfortable hold. But it does take some time for them to get their oral cavity to get bigger, where they stay on, where they're not pulling the nipple out with me. I'm sorry, my 13-year-old just came home from school early and turned on the TV. Excuse me. Lexi, honey, I'm teaching a class. Can you go watch in the basement? Okay, sorry. Sorry, guys. I thought I had till 2, with none of my people here. So then you go to the cradle hold. Football is excellent for mamas who have really large breasts and or had a C-section. So this is maybe one that you want in your back pocket, Lindsay, where it keeps the baby off the incision. You don't want any pressure there. So you keep everything off to the side. And the way you're holding your little guy is the same exact way. I got him here, forearm in line with the spine, thumb and ring finger behind his ears, and he's here. See how he's here? And I bring here, put your hand down, honey, so they can see. I bring baby to breast. Baby, sit up. I don't chase him with my boob. Baby, sit up. And now you're doing the C hold. See? The mustache, the thumb, it's in the right place, and baby goes up and over. So that's the football. And then the real graduated one is sideline. And that is so awesome when they get just big enough that you can get them on without so much technical support and they can nurse with you lying down. You're literally on your side like this and baby is up to you. And I had like a few moms lately actually with like a tailbone pain and really lower area pain. So the sideline was awesome because they weren't sitting and putting so much pressure there. Any questions with latch and positioning? You guys know all those holds? Is that kind of common knowledge? cross cradle, cradle, football, sideline?
No, I think
Yeah.
that was really cool.
Okay, good. And then you'll find when they get older and more sturdy, it's however you can get them on where they drink milk and it doesn't hurt you. But I do think it's quite technical in the beginning. I actually know it's quite technical in the beginning. Okay, question I get all the time. When should I start pumping? And the answer is it depends. If you are in the hospital and everything is going well, I think that's my first slide. Mom has milk. How do you know that? Baby isn't losing too much weight, right? Baby is having diapers. Baby is nursing well. You don't need to pump. And trust me, they eat so frequently and come to breast so frequently. And the diaper chain takes forever. And then you're putting their little onesie back on that you want to streamline things as much as possible. And pumping is a whole other step. And you want time to really rest and sit there with that. Like, where are the parts and getting the pump and honey, wash the parts and all this. So this is scenario one that you would not do it in the hospital. Baby's nursing well and mom has milk. And those context clues are going to tell us those things. Scenario two would be that mom has milk, but baby isn't latching. Why isn't baby latching? Maybe baby was born at 35 weeks and their suck, swallow, and breathing isn't coordinated. Maybe baby has to have their breathing an eye on it and is in the NICU and separated from mom, and they don't want baby coming out of the out of its little bassinet to bring baby to breast. Maybe baby has jaundice, and this is actually a great slide. Aria, that little baby there, had major jaundice. You can see that she's yellow, and that's when the baby's liver isn't working properly, and it's like toxins floating in their body. Very, very, very common. And they need to be able to poop out that bilirubin, but the jaundice makes them so lethargic that they are not nursing well and not latching. So that is a time when you want to get the milk out of you and get it into the baby. And what makes me mental sometimes is providers will see a situation where the baby's lost too much weight and the baby needs more volume, and they just flippantly recommend formula. And there's certainly a place and time for formula, but why wouldn't you try to get it out of the mom first? So I was at a mom's house recently. She's engorged and so uncomfortable. The baby's drinking formula, so they're not coming to the breast with any type of vigor because they're so full, and it really just messes up the whole supply and demand. And you have the best thing kind of sitting on the table while baby is getting something else. Absolutely makes no sense. The other situation is if mom doesn't have the milk. So my little guy is nursing beautifully. He's trying, he's sucking, he's rhythmic, but do you know, you guys, I have a client right now who's 50. Isn't that wild and kind of awesome and kind of crazy all at the same time? I think she's such a rock star, but her milk was delayed coming in, right? There's advanced maternal age is certainly a factor there. So we can't let Hazel starve in the meantime. So that's when we would start pumping, and she doesn't have the milk, then that's when something like donor milk or formula would be appropriate. And that's another time that you would pump. In that situation, pumping is going to get the memo to the brain of like, hello, there is a baby here. We need to get some milk out and into the baby. And most common is a C-section. And some moms, like Lindsay, I have some moms who come out with milk everywhere, even with a C-section. It's not an automatic. This is typical. But C-section mamas may want to start pumping in the hospital sooner than later. Moms who are advanced maternal age, let's just say 40 and up, or if you have a history of delayed onset. So if your mom's milk took forever. You're 35, that's like my average age now. I mean, this area, I would say most of my clients are around. Actually, I just looked at it for 2022 and 23. I just took the average. My average mom age is 33, which is so different than when our parents had babies, right? So it's just, there's some things that are a little different there. And the name of the game with pumping. So those three scenarios that I just went through are basically from in the hospital. How do you assess if you need to pump right after delivery? But we're going to assume for now, this next session, that baby didn't lose too much weight, baby's with you, nursing well, and you've been breastfeeding for, exclusively breastfeeding the first several days, and you're starting to pump to either introduce bottles or start stockpiling, and that would obviously be beyond a few days. Your golden rule is you have to move milk to make milk. So when you are pumping, you have to get it out of your body to then make additional milk. That's kind of the motto there. So how long and how often? Again, it depends. Are you pumping to stockpile, or are you pumping in lieu of breastfeeding for some reason? The scenario one is baby's nursing well and mama's has milk. So the recommendation is not to pump for 4 weeks. Get breastfeeding well established. Make sure that baby has the latch down, and you wait 4 weeks to pump and give a bottle. I'd say 90% of my clients, though, do it more often than them. I mean, there's a sleep deprivation. There's different scenarios where, I don't know, maybe they're exclusively nursing for the first week, and then they want to start doing bottles for dad to do a bottle or partner to do a bottle in lieu of them nursing. And in that situation, you're nursing baby, and pumping could be an entire webinar on its own. But in that scenario, I'm nursing my baby. You make the most milk in the morning, so that's when you're going to get the most ROI for your pumping. So I feed this little guy at 6 a.m. I pass him off, and then I pump for 15 minutes. And that's going to be my nighttime feed, right? That's going to be my overnight bottle. And then you're just kind of getting ahead of it. So then the next night at 3 a.m., dad gets up and gives the milk that I pumped from the night before. And you have to, someone or something has to be draining milk from you. So then at that time, it doesn't have to be at the same exact time at 3 o'clock, but you're going to have to pump. So again, is it really worth have dad given a bottle? Because you're going to have to get up and drain that milk from you. I'm sorry, Mom, I didn't see that question. If you want to pop it back up there. And then
I just said, is it 15 minutes per breast or 15
no,
minutes?
total. Yep. And you put both of the flanges on, and you do 15 minutes total. So that's the tricky thing with someone else giving a bottle, is that if dad gives a bottle, you have to get that feeding out of your body. Now, breastfeeding baby nurses, any guess how long a baby is at breast initially for the first several weeks? Like how long you're sitting there with them nursing? 10 minutes, 20 minutes? It's 40 minutes, 30 to 40 minutes. So there is something to be said at 3 a.m. Dad does the bottle and you're pumping, because pumping will take 15 minutes. And then you can go back to breastfeeding during the day. And kind of a hack for sleep is you're nursing baby all throughout the day. You do the breastfeeding at midnight. Baby needs to eat at 3 a.m. So dad gets up at 3 p.m. and does the bottle. And this is where it's hard for mamas, but you have to stay asleep, right? You have to stay asleep and take advantage that he's actually doing the bottle, and not get up with him and say, no, hold it like this. Or she said, don't put it down there, or you're doing it wrong. You got to keep sleeping and take advantage of that extra hour. And then you would get up at 4 and pump. So at least you have a 4-hour block of sleep overnight. And then you have to get up at 4 and pump. And then you're back on the schedule at 6 a.m. Does that make sense? So it gives you a break, but you have to get up and do something anyway. But an extra hour in the postpartum days could be like a game changer there. But back to that mantra, you have to move milk to make milk. So if dad's doing the 3 a.m. and you're sleeping till 6 a.m., you're going to get super engorged and possibly get mastitis, and eventually your supply will go down. Someone or something to pump needs to be consistently moving milk from you. Oh, there we go again. So the recommendation of when to give a bottle is after breastfeeding is well established at 4 weeks, what I'd said before. I have a mom who's like been through it at birth and has like a really challenging recovery and doesn't feel good. And I say you use it to how it best fits your family. Again, it's kind of like this all or nothing, these rules I'm not a big fan of. Would it be optimal to breastfeed and really get it down? Yeah. But would it be imperative to mom to get a block of sleep and her mental health being a big part of it and actually be able to like form a sentence the next day, use a bottle? Yes, definitely. And I don't think these hard and fast rules of like no pacifiers or no bottles. I mean, I've just supported thousands of families. It just doesn't work like that. You just don't like screw everything up because you broke one of these rules. They're guidelines, they're recommendations, but you would give a bottle. Again, some mamas in the hospital need a bottle, right? If my baby lost 12% and my milk is like nowhere to be found yet, I'm going to do a bottle. So it just really depends. But think like 4 weeks and then do what kind of works for you. Any questions on that? A bottle, they all say slow flow. They'll all say it with the marketing, but when you turn your bottle upside down, put some water in it, you don't want it beating out. And you have to test each one. I'll have like a Dr. Brown's and they both say preemie nipple and one floods and one doesn't. And I don't know if because they're made in different factories or what it is, but I'll have a Comotomo that is really slow and another one that just beads out. So when you get your bottles and you sterilize them, put a little water in them, turn them upside down and make sure that it just doesn't bead out where baby just basically goes like this. You want that baby to have to pull that milk out and work to get that milk. So when they go back to you, it's not a lot of times bottle confusion or nipple confusion. It's flow frustration, right? They get pissed. Where is that other tap? So we want to make the bottle like really hard for them to pull it out. And then do paste bottle feeding. You don't want to feed your baby a bottle like this, like we see on TV, right? You want to sit them up. So I like to sit on my family's couches, and if there's a coffee table in front of them, and I put my knees up like this, okay? And then I put my little guy here, and I'm holding him just like we do on the hold, and I'm feeding him like this. Hey, buddy. You can kind of look at him too. You're not going to slam this. So then when you go back to breast, you're not going to be so aggravated that it's not just coming out. And you have them take it slow. And yeah, there will be more air in there. Everyone asks me that, but it's the lesser of two evils, right? You just burp them well. But you don't want this. And not to knock on our parents, but it's like the grandparents always do this, right? Sit them up, make them work to get the milk out of the bottle. Yeah. Another thing about pumping and bottle feeding, should you bring your pump to the hospital? Should I have the lactation consultants at the hospital check my flange size? And I would just keep your bag minimal. If you need to pump in the hospital, they will provide a hospital grade pump, and it is the Mac Daddy. So it's so much more efficient and stronger and a better pump than bringing your Spectra or your Medela Freestyle. So I would not. And I think also the flange size like freaks everyone out, and they want to know like when they're pregnant what they need. And it is kind of tricky. It is a little bit of a trial and error because you want your nipple to go in that flange like this. But what happens when you start pumping, then the nipple plumps up. So we got to kind of like, that's one of the things that I do with my clients on visits. Like, well, let's just see. And we don't want any rubbing. So if it goes in, it's like this flange is too small. If it's going this and the areola is going in that shaft, then this flange is too big. But that's something that a lactation consultant could help you with. Yeah, everybody got their pump? Yeah, Spectra. I feel like that's the most popular one. Yeah, everyone have a Spectra? Yeah. Their flange sizes, you just want to make sure with them that you have the correct flange size. with any of them, but the Spectra seems to be a bigger, even if I have a 24 Medela and you have a 24 Spectra, I feel like the Spectra is a bigger shaft there. And most moms are smaller than what they give you a 24. Most moms are like whatever is the next one down, which I believe is like a 21 or a 19. If you have big fat raspberry like nipples, then you'll be one of the larger sizes, but most moms are more like pencil eraser type of a nipple, if that makes sense. And then a smaller one would fit better. Okay, so we went over breastfeeding in the hospital, when you would pump in the hospital, the latch and the positioning, and then pumping for your life and introducing a bottle. Anything else that you guys want to know? Anything else that somebody told you that you're like, is that true? Anyone feel more empowered? Like good overview?
Yeah, definitely.
Yeah. Awesome. No questions? I love the crazy stuff that people hear.
I have one question.
Yeah.
Because in the unfortunate case that milk is babies either losing a lot of weight, etc., and we have to pump in the hospital, is the handling of colostrum similar to the handling of, I guess, normal milk, because it's so small in quantity? So
Mhm.
what are you expecting to do with that? Like how do you, it's like, I mean, comparatively it's a big container and a few drops. I imagine I'm maybe exaggerating, but I remember I didn't do that part. Like I skipped it because I was supposed to let the milk come down and see what happened, right?
Mhm.
So I'm wondering that part. How does it really work?
Yeah, no, I completely understand your question. So baby latches on and we're going to assume they're getting the colostrum. You don't see it. It's not dripping down their face in most cases like mature milk is, but we're just going to assume. But the doctor comes in, says your baby's lost 10%. We got to get some food in them. So the first thing I would do is try to hand express. And I'll tell you, when you're day 1 or day 2, hand expressing, I'll send you that video too, is more effective than a pump, because you're literally milking yourself and you literally can get more to the ducts and get it out. And you're going to pump it onto a clean spoon. At Sibley Hospital, we would go down to the cafeteria, get a spoon that was wrapped in plastic, so it was sterile, take it off, and then pump it onto the, not hand pump it, hand express it onto the spoon. And then a lactation consultant will help you like have the baby lap it off, and they look like a little kitty cat. Right. And just that could be enough to get them going. That's the way that I would administer it. Or if you get a more copious amount, you're putting it in a syringe. And I always like a lactation consultant to hold you, because you don't want to blast it in the back of their mouth, and you're trying to be very cognizant of aspiration, but you're getting it in through a syringe. But you're right, like pumping colostrum into a big receptacle bottle, you're going to lose half of it, maybe all of it on the sides of the bottle. So that's a great question. And in that same vein, I'm going to just mention the harvesting colostrum. Have you guys heard of that? That you start like milking yourself before the baby's here to take to the hospital. My thought is you don't have to do that. Your body will have what it needs when the baby arrives. However, I feel like it's like trendy right now. You know, these different trends go where people are talking about it and doing it and putting them in syringes to put in the freezer to bring to the hospital. And if that's the case, I just wouldn't start hand expressing my breast any sooner than 38 weeks, maybe even 39, because that's something that can very easily send you into labor. Yeah. Yeah. I say just wait, but I'm working with a client now, and she had such a low supply with her first, and she has PTSD. So we, started in the hospital with maybe 20 mLs of colostrum, just so she had. But what's so nice is, and she delivered at Sibley and they did not, but I know at the Inova hospitals, they have donor milk, which is awesome. I'd give donor milk to my baby, and that would have sounded really weird to me before I was in lactation, but now I'd give donor milk to my baby, especially from the hospital. It's all pasteurized, like 8 days a week over formula.
Oh, wow.
So probably available to you. That's something to ask Lindsay for your hospital as well.
Yeah, I have a quick question about that. So I So I have gestational diabetes, and that's partly why we're delivering early, and other issues too, making me do a C-section. But so they're delivering me at 38 weeks and 3 days. It's July 5th is 38 weeks and 3 days.
Okay.
So I have a lactation consultant that I've hired that has already come and done like a prenatal consultation with me.
Yeah.
She said that harvesting colostrum is a good idea in that case, just because I don't know if he has to go to the NICU, or I don't know yet, you know. And she said 36 weeks is okay.
Yeah.
And my doctor said that should be okay too, but if I start cramping, to stop.
Yeah.
So is that what you would say in that case?
Yeah, I guess I'm just more conservative, you know,
Yeah.
like
I would like to have some on hand.
I would love for you to have some. I also would love for you to have a 38 weeker over a 36 weeker.
Mm-hmm.
You know what I mean? Like, I would love for him to cook, or her to cook, a little bit longer in there than having colostrum on standby. So it's a decision between you and your doctor. What may make that decision a little bit easier is call the hospital and see if they have donor milk readily available. Because if your only other option was formula, then maybe you're motivated to. But and this isn't even necessarily research based, my 38 weeks. But I know the difference between a 38 weeker and a 36 weeker and a 40 weeker. And I would like, you know, if we can prevent it, then born closer to term. So, yeah, but I would confirm with your doctor. And she said if you stop cramping, but I wouldn't want to
make it too late.
Labor. Yeah. I personally wouldn't think it was worth having 5 mLs of colostrum and then having a 36-week baby. And I'm not saying it's going to happen. Yeah.
I mean, I'm producing already. Like, it happens a lot. So if I all of a sudden notice I'm like leaking, like maybe just try to get some then.
Collect the leaking. I think that's an awesome idea. Yeah. Okay. I think it's an awesome idea. I would collect what you can without manually compressing your breast. And let's see what you get. And you still have a couple weeks, and then maybe, you know, a week before you really start cranking out with the hand expressing.
Okay. Maybe wait till like 37.5 weeks or something.
Yeah, that's a good compromise. Yeah, that's a great compromise. Yeah, no, that's awesome.
Sorry, I know that might just be related to just me. I'm
no,
sorry.
I mean, these babies come early all the time. All the time. I have one due tomorrow that I've been working with her for 2 weeks already. So okay, I'm going to send you guys the breast crawl, the diaper chart, the pain-free latch guide, and the hand expression video. So you're going to get lots of goodies here in the follow-up email. Of course, I would love to work with you. I do all in-home consultations. Most of my clients book me before they have the baby. I am filling up and do travel for July and August, but certainly have spots. Because you guys joined the class, if you wanted to book me before June, I'll credit the class to the cost of the packages. So you would get $50 off. If you want to learn more about the packages, you can book a call for me. It's 15 minutes. I just walk through what you would get working with me and the pricing and next steps to working together. But if not, I think that this was even just a great nugget for you guys to take away for your breastfeeding journey. You guys are going to do awesome. Just the fact that you're proactive and here, you're going to do awesome. Sound good?
Yes. Thank you so much.
Okay.
Can you please also share the slides if there's no problem, or
the recording?
The presentation.
Yeah, the recording will include the slides.
Whatever. Yeah.
Yep, I got it.
Thank you so much.
Okay, guys, have a great weekend. Any questions, just let me know.
Good luck, everybody.
Take care. Bye.
Take care. Bye.
Bye.